So good morning everybody, and as we continue this same topic, which is really the heart of glaucoma imaging, we will just see how we do the clinical workflow in terms of the BMO positioning. Has it come? Yeah. So after knowing how to do it, we will see how practical it is. So this was history. So this is out and this is in. Now this is very important that individualized marking of the scanning circle is out and automated marking is in, and that this itself is the holy grail of imaging. So BMO is the holy grail of advanced glaucoma imaging, is something that everybody should know. And BMO is the Bruch's membrane opening, as we have seen. So it's not clinically visible, it's BVR, like the BVR missiles. You don't see it at all, and the machine fires it for you. What it gives you is the repeatability and reproducibility, because of which it has made progression assessment a real possibility. It is user independent and it is automated. So all these make it a reliable tool for minimizing the test-retest variability, and this really differentiates the men from the boys in glaucoma imaging. So deviation in clinical disc margin and the BMO is very well known. Why manual is out and automated is in is this, because in the manual you cannot see the Bruch's membrane opening, because of which you cannot mark the clinical disc margin. So this BMO is way out of the clinical margin. This is nearly similar and this is superimposed. This is impossible to detect by the human eye, because of which it will also affect the scanning circle in the RNFL analysis. So posterior segment imaging in glaucoma consists of the ONH, the RNFL and the macula, as rightly pointed out by Swati. The correlation of these three and the one neuron concept is very important, and we have to never report each and every structure in isolation, which was the mistake committed in the last few decades. Masterly workflow makes the difference between use and abuse is something that we should know. So the study of OCT for glaucoma begins here with this image, which is not available with most of the machines and which is not seen by most of the ophthalmology consultants. So when we see the BMO overview, we get the segment-wise view of the Bruch's membrane opening, which we can verify. We verify the segmentation, verify the positioning, and see that everything is in order before we go to the next step. So go to this. Because it is not available in many devices, this image is not seen in any of the printouts which are described in common lectures. Now, why precision and checklists matter is very important, because there are certain things which cannot be missed. One is the rim analysis. Once you've done the checking with the BMO points, you go to the rim, then see for the profile. If you see the profile and if you see local dips, you can go again to the same sector and recheck the placement of the Bruch's membrane opening. And then second thing is you go to the deviation of the Bruch's membrane opening. Now if that is more than 100 microns, you know it is not comparable to the normative database, because of which the color coding will go for a toss. So these are very, very fine things, and precision matters when you use this for glaucoma serious glaucoma imaging. Now you can see the effect of the BMO on NFL scan circle placement. Because you cannot see the center of the BMO, here you may be sometimes right in placing the scanning circle, but here there is no way you can place the scanning circle in the position which is required, because you just can't identify the BMO. So this is very, very important clinical correlate why BMO centration and automation is very, very important. Now BMO overview, the examination in all centers, all sectors, and localizing it and classifying it is due diligence, without which you should not be proceeding with the analysis of a particular image. So due diligence is mandatory, otherwise there is no difference between use and abuse. If you can see here in this image also, you have BMO localization that is precise. In every sector of the 12, you can see the BMO and the ending precisely, very, very clearly, even clear to the normal human eye. And all the sectors are classified depending upon the normality in terms of red, green and yellow color coding. Very, very simple, very easy, but mandatory. Knowing that, you have to know that imaging has its own limitations and identification of which is important. Now if you see this image again, the due diligence that you are doing, you will see the image below here which has gone for a toss. So irrespective of how good your device is, optical devices have their own limitations, and you should be absolutely sure of what you are looking at. So in such cases, try to reacquire, alter the image contrast, look for the choroidal wedge, and redo the BMO at suspect locations. Now this all is not possible with most of the machines except the Spectralis, and that is what impressed me the most about this machine. I have no financial interest though, but this gives you the cutting edge in ophthalmic diagnostics as far as glaucoma imaging is concerned. Look at this, you have to beware of disc tilts and torsions. It is an immediate red flag. The moment you see a disc like this, you have to go to the 12 images to sort out whether the BMO has been identified correctly. And as you would realize here are the few places where the BMO location visible to your eye and what is marked by the machine is different. So the moment you see this, you have to be sure that, or you have to be reasonably sure that there may be some variation as compared to what you should be anticipating clinically. So it's very, very important to see these sectors and put them in proper perspective before you go to the normative database and compare. Having said that, comparing such discs to normative database is fraught with danger. You can do it with the RNFL or the macula rather than doing it at the disc margin in such kind of cases. Again, in this case, you see the Bruch's membrane opening is lying somewhere else, the clinical disc margin is lying somewhere else, and rightly here you can find out that there is no data that is being acquired, no marking that has taken place. So why this is important is in some kind of optic nerve heads, irrespective of the number of times you do the examination, it is impossible to get the Bruch's membrane opening, and which is a limitation that you should absolutely understand. Clinical correlation is very important, and this is another example of of such a case. Now here you can see all the sectors are green. So even though all the sectors are green, doesn't mean that everything is normal, because this is just an image. This is not going to give you an answer. This is going to help you answer. So just remember that clinical correlation is the most important thing, which we shall see in continuation in the next episode. That is my next talk of the next 6 minutes. Thank you for your patience.